Hello, everyone. My name is Karuna Shekdar, and I'm a pediatric neuroradiologist working at Children's Hospital of Philadelphia. And today I'm going to talk to you about pediatric brain tumor imaging. This is a very big topic, and I could give a lecture on almost every type of pediatric brain tumor separately. But we don't have the time to do that. So what we're going to do today is just do an overview of common pediatric brain tumors, and we are going to do that based on their location. And we will also discuss some characteristic imaging features of the common brain tumors. Now, brain and other CNS tumors are the most common form of solid tumors in children. And also, brain tumors cause the majority of cancer-related mortality in pediatric age group. These statistics I've referred to from the CBTRS report, which is the Central Brain Tumor Registry of the United States, that came out in 2018. Childhood brain tumors are different from adult tumors. First of all, in adults, there are a large number of glial tumors, which are going to be malignant in majority of the cases. Whereas in pediatric tumors, the frequency of glial tumors is less and they are more likely to be benign. Metastatic brain tumors are far, far more common in adults than children. Primary infratentorial tumors are more common in children than adults. And CSF dissemination is a feature which is more commonly associated with childhood brain tumors. Now let's look at the imaging modalities we utilize in the evaluation of brain tumors. So MRI is the primary imaging modality. It is useful both in diagnosis as well as in follow-up of brain tumors. You can utilize the advanced imaging tools such as MR spectroscopy, diffusion tensor imaging, and arterial spin label perfusion for further characterization of tumors, and also has an important role in providing the pre-surgical navigation to help the surgeon in the OR for resection of tumors. Computed tomography or CT scan has its role. It helps in identifying calcification in these tumors, specifically with respect to osseous landmarks. It is useful. The CT navigation is particularly useful. For example, if a surgeon was going to do a craniopharyngioma resection via a transsphenoidal approach, then it is more likely that they are going to request a CT navigation study prior to surgery. And also, in all emergency situations, a CT scan is going to be the modality which is going to be used because it is much easier and faster to obtain with lesser need for sedation. Now, if you look by the tumor histology, this pie chart kind of depicts the different types of tumors by their histology. You'll notice that the biggest group of these is composed of Pilocytic Astrocytomas, which account for about 1/5, about 18 to 20% of all pediatric brain tumors. And the second big category I would like to point out is the embryonal tumors. And among these embryonal tumors, Medulloblastoma is far more common, accounting for about 62% of these embryonal tumors, and a category which is very typical or characteristic to the pediatric population is the ATRT group, subgroup of the embryonal tumors, accounting for about 16% of brain tumors in children. You must have heard this, that location is everything in the brain and brain pathology. So based on location, we can look at the different categories of pediatric brain tumors. And we are going to start this journey of looking at brain tumors by starting from below. We're going to start with the posterior fossa group of tumors. Then we'll proceed to looking at brainstem tumors, then followed by the pineal region tumors and tumors occurring in the cerebral hemisphere, with special mention of supracellular category of tumors, and then some miscellaneous group of tumors. So let's start our journey with the posterior fossa tumors. So the first among this is going to be medulloblastoma. This is the most common posterior fossa brain tumor in children and accounts for about 15% of almost all pediatric brain tumors. This used to be formerly known as primitive neuroectodermal tumor, or PNET, and this terminology of PNET is now removed from the diagnostic lexicon after the 2016 revision to WHO brain tumor classification. Medulloblastomas are highly cellular embryonal tumors with a WHO grade of 4, and that is what accounts for the restricted diffusion, which we see on MR imaging. The classic location of a medulloblastoma is its origin from the fourth ventricle. It's usually the roof of the fourth ventricle, which is also the dorsal wall of the fourth ventricle. It produces obstructive hydrocephalus, and CSF dissemination is very common at presentation. I just want to tell you that there has been a classification of medulloblastomas by the molecular subtypes into 4 categories. And these are, we don't have time to go over the details, but these are important for management as well as in predicting the prognosis of the tumor. So let's look at a classic example. Now, this is a medulloblastoma with its classic location, which is arising from the dorsal wall or the roof of the fourth ventricle. On CT scan, because they are highly cellular tumors, they are going to be slightly hyperdense than the brain parenchyma. And very often they produce obstructive hydrocephalus, which is evident on the CT scan. On MR imaging, they are typically solid tumors, slightly brighter than the brain parenchyma on T2-weighted images. They may be heterogeneous with some cystic components. Enhancement within these tumors is variable, but typically not very intense when they enhance. But the most diagnostic feature that is helpful to diagnosis at a medulloblastoma is going to be restricted diffusion with low ADC. And this is due to the high cellularity of the tumors. This is another example now of a medulloblastoma with some enhancement. And you can notice that there are multiple nodular and linear enhancement in the subarachnoid space of the brain, as well as the entire spinal cord, coating the surface with multiple nodular and linear enhancement throughout the spinal canal and also at the bottom of the thecal sac. At least about 1/3 of medulloblastomas will have metastasis right at the onset of presentation. Sometimes the medulloblastoma may not be the classic midline location, but they can be more lateral, located in the cerebellar hemispheres like we have here. In this case, again, appearing slightly hyperdense in the right cerebellar hemisphere. And this case probably also had a metastatic deposit at the time of presentation, as you can see by the hyperdensity on the left side as well. On MR imaging, you can see this large, predominantly solid mass with few cystic areas in the cerebellum displacing the fourth ventricle with partial effacement, and some areas of enhancement within. And again, notice the characteristic diffusion restriction and the low ADC, very typical of medulloblastomas. Moving on, we now move to the next category, which is Pilocytic Astrocytoma. This is the most common brain tumor in children. It was formerly known as juvenile pilocytic astrocytoma, but the term juvenile is usually dropped now, and we refer them to as just simple pilocytic astrocytoma. And they are typically WHO grade 1 and have a typical benign course in majority of the cases. The classic appearance and location is within the cerebellar hemisphere. It will appear as a cerebellar cyst with a mural nodule. Typically, a pilocytic astrocytoma at presentation, the cystic components are quite large and have been shown to be at least around 5 centimeters in size at presentation. They can have calcification and hemorrhage within. Other locations besides the posterior fossa, they could occur in the cerebral hemispheres, in the hypothalamus or the optic chiasm, and they can involve the optic pathway in patients with neurofibromatosis type 1. So let's look at the imaging features. On CT, here you can see the classic imaging appearance of a large cyst within the cerebellar hemisphere, the right hemisphere in this case, with this mural nodule. And because of its mass effect on the fourth ventricle, patient is also demonstrating features of hydrocephalus. On MR imaging, you can see this is in another case. You can see the large cyst, which is typically following fluid signal on T2 and T1. And you can see the more solid mural nodule, which is showing enhancement. And notice the absence of diffusion restriction in this case. On the contrast enhanced image, you can notice that there is some mild enhancement along the rim of the cyst. Some other appearance seen with pilocytic astrocytoma, like demonstrated in this case, is a more lobulated appearance, a slightly larger nodule now, which is showing more thick nodular enhancement as well as enhancement along the margin of the cyst. But want to point out again that in the mural nodule, there is absence of diffusion restriction. You may also notice that there is a level within the couple of the large cysts within this tumor, which is probably due to blood products because of the low signal that we can see here. Other locations of pilocytic astrocytoma, like I mentioned before, can occur in supratentorially in the cerebral hemispheres. They could occur in the hypothalamic chiasmatic location, like we are seeing here in this case, or in cases with neurofibromatosis 1, it can involve the optic pathway. Here as you're seeing it, when it involves the optic pathway, some of them may not show any enhancement at all, and it's more solid appearing. And here you can see there is an example of an enhancing optic pathway glioma, which are all pilocytic astrocytomas by histology. At this time, I want to talk about an entity which is usually seen in older children, which also has a cyst with a mural nodule. But the difference here that I want to point out in this case is that the nodule is intensely enhancing, and quite frequently this nodule is noticed to be on the PL surface or the margin of the cerebellum or the posterior fossa. And they may be isolated or single, or sometimes when they are multiple, then you need to consider the von Hippel-Lindau syndrome, which is characterized by multiple hemangioblastomas commonly seen in the posterior fossa and in the spinal cord. There may be associated findings in the visceral organs like the kidneys and the pancreas as well in von Hippel-Lindau syndrome. Moving on to the next entity in posterior fossa tumor is the Ependymoma. These account for about 15% of pediatric posterior fossa brain tumors. And typical location is the fourth ventricle. And in contrast to the medulloblastoma, ependymomas arise from the floor or the ventral wall of the fourth ventricle. These tumors are moderately cellular, and the ependymomas have a sort of plastic nature to them, and they easily move and extend into the foramina of the fourth ventricle, the midline foramina of Magendie, or lateral recess of the fourth ventricle, which are the foramina of Luschka. They are typically heterogeneous, have cysts, they can have calcification and hemorrhage, and usually show more intense enhancement of their solid components compared to other posterior fossa tumors. They can cause obstructive hydrocephalus, and CSF dissemination is again commonly associated with ependymomas. I want to talk about an entity which is the supratentorial ependymoma, but this is genetically distinct and has a different behavior than the posterior fossa ependymoma. So let's look at some examples on imaging. So here we have a lobulated mass lesion on the CT scan, which is expanding and compressing the fourth ventricle. I want you to notice that this one, the attenuation of the mass is not typically higher than that of the rest of the brain, in contrast to medulloblastoma, which is more likely to be hyperdense compared to the brain on unenhanced CT scan. And also, again, this tumor is also causing hydrocephalus. On MR imaging, you can notice this is a more heterogeneous tumor, which has both solid and multiple cysts within. And on contrast, you can notice the more intense enhancement that is visible in ependymomas when compared to, say, medulloblastomas. You can see in the sagittal image the extension of this tumor into via the foramen of Magendie inferiorly. And on the axial image here, you can see the extension into the right foramen of Luschka. Notice here that this tumor had a lot of susceptibility, which could either be due to blood products or calcification, as seen on the susceptibility weighted image here. And notice that this tumor actually did not demonstrate any restricted diffusion. Now, that could be variable because restricted diffusion could be seen in the anaplastic variety of ependymomas. The next category is going to be the atypical teratoid rhabdoid tumor, or simply known as the ATRT. This tumor is a highly malignant embryonal tumor, WHO grade 4, which is common in young children, mostly less than 3 years of age. The location is usually of the ATRTs is most commonly in the posterior fossa, but it can arise anywhere in the brain, in the supratentorial brain, or even in the spinal cord. On imaging, they are typically large, heterogeneous, with cysts, can have calcification, and hemorrhage is very common, and they also have a very rapid growth rate. They can produce obstructive hydrocephalus, and again, CSF dissemination is common with the ATRT group of tumors. And one easy tip to consider or make this an easy diagnosis is to consider when you see anything big, bad, or ugly in the posterior fossa, or for that matter, in the brain in a child less than 3 years of age, your ATRT should be included in the differential. A bonus information for you guys is that ATRTs are associated with the SMARC-B1 gene mutation, and there is lack of immunostaining for INI1. So on imaging, on a CT scan here, you can see the first thing is that this is a large tumor with in the midline with the cystic and solid components, and maybe some areas of calcification, and also causing hydrocephalus. The most important clue for me when I'm looking at this case is going to be the age of the child. So if it is an infant less than 1 year or someone who's less than 3 years, this category of tumor should be considered for any big, large posterior fossa mass. On MR imaging here in this example of ATRT, you are seeing this very large heterogeneous mass with solid components, cystic components. There are blood products, hemorrhage within, which is much more well demonstrated on this sagittal image, the areas of T2 dark signal, which is the hemorrhage and cysts and solid components. Again, notice the extent of the susceptibility on the susceptibility weighted images. And the solid component of the ATRT almost always shows diffusion restriction. So your best clue again is the age of the kid. And when you see something big, bad, ugly with hemorrhage, calcification, diffusion restriction, think of ATRT. So ATRTs need not be just in the posterior fossa. They can be supratentorial, seen in the supratentorial location, like you're seeing here, a lobulated big mass in the left cerebral hemisphere, which is causing mass effect on the lateral ventricle. And notice the very pronounced diffusion restriction in the solid component of this tumor. I'm just going to take a slight detour and mention another malignant tumor which may be seen in the children. They're usually seen in older kids about which are close to adolescents or young adults. You can see this tumor, which is far more common in the adult population, but can be seen in children as well. And the hallmark of glioblastoma on imaging is usually a large mass which can span more than two lobes of the brain and has large necrotic components, which may be common and usually demonstrate very low ADC, demonstrating the increased cellularity of this tumor. They can have a varying degree of infiltration adjacent to the tumor and a varying degree of enhancement within. Just want to point out that the term glioblastoma multiforme has been dropped, and we just refer to this group of tumors as glioblastoma. So moving on with our journey, we looked at posterior fossa tumors. Now we turn our attention to brainstem tumors. So one of the most common brainstem tumors in children is the entity of diffuse midline glioma, which was also formerly known as diffuse intrinsic pontine glioma, or DIPG. Among these tumors, there is a variety which has the H3K27 mutation, which has the worst prognosis. DIPGs or DMGs are expansile tumors. They're infiltrative in nature and typically centered in the pons. Other locations of the diffuse midline glioma would include the thalamus and the basal ganglia as well. They demonstrate a variable enhancement, at least in the initial phase. In the later course, they can start showing enhancement as well as development of areas of necrosis within. So on imaging, here you can see a classic example of the pontine glioma, which is produced and has an expansile appearance. And on MR imaging, you can see, because of the infiltrative nature of the tumor, you can it has produced this typical tigroid appearance on the axial images. Very often, this tumor will be ventrally exophytic and will cause at least some partial encasement of the basilar artery and can extend posteriorly and cause mass effect on the fourth ventricle. Unfortunately, the prognosis of these tumors is generally very bad, and radiation is the only treatment which is utilized, although many other experimental treatment regimes are under investigation right now. So here is an example of another pontine glioma, the diffuse midline glioma centered in the pons. You can see that there have been changes. This patient had undergone biopsy of the pontine glioma and also underwent radiation. You can see some intrinsic areas of cystic malacia as well as T2 bright areas, which are probably secondary to the radiation treatment, which have developed within the pontine glioma. Moving superiorly, we will now look at gliomas in the tectum. Now, these are going to be also mostly astrocytomas, and majority of them are low-grade astrocytomas located in the tectum. Now, because of this very characteristic location, when the astrocytomas or gliomas arise in the tectum, they can cause mass effect on the aqueduct and result in hydrocephalus. They also cause mass effect on the superior collicula and present clinically with ophthalmoplegia. And superior gaze palsy is a typical presentation with tectal gliomas. And very often, the only treatment which is done in the case of tectal glioma is to provide a CSF diversion or treat the hydrocephalus, which could be done either by VP shunting, or what is more commonly done at our institute is you do an endoscopic third ventriculostomy. You come from above and make a fenestration in the floor of the third ventricle, which is the Lilliquist membrane, so that you can have a diversion for the hydrocephalus and you can decompress the hydrocephalus. So you can see here in this case, following the third ventriculostomy, which is evidenced by this dark jet, as we see on the sagittal T2 images, the extent of the ventricular dilatation has gone down. This is an immediate post-ETV study. And many times that itself is the treatment, and the patients may remain asymptomatic even though the tumor remains in the tectum. You just follow them up to see that the tumor is not growing, and that should be the only treatment in majority of the cases, a CSF diversion for tectal glioma. Now we move to the pineal region tumors, and the two main entities in this group are the Pineoblastoma and the Germinoma. Pineoblastoma is a malignant primitive embryonal tumor of the pineal parenchyma, and it is characterized by a blasted pattern of calcification within, and it can be associated with familial retinoblastoma and DICER1 mutations. Germinoma is a tumor of the primordial germ cells, and it can be in the pineal location, or it can be in other locations like suprasellar and basal ganglia location. And they can have calcifications. Typically, the calcifications in germinoma is going to be very chunky, clumped, and engulfed type of calcification. So let's look at how it looks on imaging. So this is a comparison of a germinoma and a pineoblastoma calcification as we see on CT. So classically, in germinoma, you have more chunky or clumped and engulfed calcification. The calcification is engulfed by the tumor. And here in this case, there's also, again, is a mass in the pineal region, but notice the calcification within it has a more infiltrative or an exploded appearance within the tumor. And this is typical for pineoblastoma. So we saw the appearance on CT, so let's look at the appearance on MR. And you can see this heterogeneous lobulated, predominantly solid mass in the pineal region, which is causing, which because of the location can cause mass effect and result in hydrocephalus. And because it's an embryonal tumor, you will notice that there is restricted diffusion in the lesion. So this is, when you see restricted diffusion in a pineal region mass, it's more likely going to be a pineoblastoma. And remember the association of pineoblastoma with retinoblastoma. So the familial variety of retinoblastoma are often bilateral. So when you see the combination of a bilateral retinoblastoma with a pineal region mass, or a pineoblastoma, you are going to label this as a trilateral retinoblastoma. And there is another entity called the quadrilateral retinoblastoma. When you have bilateral retinoblastomas, you have a pineal region mass, which is the pineoblastoma, along with a suprasellar mass. And when you have these three together, that is a quadrilateral retinoblastoma. For some reason unknown to me, this question of trilateral and quadrilateral retinoblastoma is a favorite on the exams and all the board exams. So please remember that association. Now let's look at germinoma. This is again a pineal region mass here with the engulfed chunky calcification on CT. Pineal region mass, which extends, has a bithalamic extension with, in this case, you can see a couple cysts within this tumor. And also this germinoma is demonstrating restricted diffusion. But this is not seen in all cases of germinoma. It is variable, the feature of diffusion restriction. But based on the characteristics, you can of the calcification and the extension, which is on either side of the third ventricle into the thalamus, this is more typically seen with germinoma. When you have a germinoma or you see a lesion in the pineal region, you want to definitely take a look at the suprasellar region and identify if there is a mass present there. And you have this entity called biphasic germinoma, where you can have a germinoma located in the pineal region as well as in the suprasellar location. And you can see this here on the sagittal T1 with contrast. There is enhancement in both the suprasellar and the pineal location of the germinomas. After this, we are going to look into the supratentorial neoplasms. So pilocytic astrocytoma is a common supratentorial neoplasm, and we have this other entity called the glioneuronal group of tumors. These are benign tumors which have both mixed glial and neural elements within them. And this group is notorious for producing seizures. They are actually the seizure-producing tumors of childhood. And it is very often common to see a cortical dysplasia associated with these tumors. And the two important entities in this group are the DNET, or the dysembryoplastic neuroepithelial tumor, and a ganglioglioma. So DNETs, they are typically characterized by their multicystic or bubbly appearance and cortical location, mostly supratentorial, and generally do not show any enhancement. Whereas gangliogliomas, they have both cystic and solid components, and enhancement is very common. A favorite location of gangliogliomas is the temporal lobe. So let's look at a case of DNET. So this is a cortical-based bubbly lesion. And you can notice here, this does not demonstrate any enhancement on following contrast. And this is just another look in the coronal plane. And they are slow-growing tumors. And because they are so close to the cortex, they can actually cause a smooth scalloping of the overlying calvarium. This is a feature which can be associated when they are large, and because of the slow-growing nature, they can produce this appearance on the adjacent calvarium. Here we have an example of a ganglioglioma. Now this is another cortical-based mass extending into the subcortical region, has both solid and cystic components, enhancing solid component. And notice its very typical location in the temporal lobe. They can vary in size. This is an example of a smaller one, but they can also be large in size. And any solid cystic enhancing lesion in the temporal lobe in a child, a ganglioglioma is has to be in the differential. I want to now talk about a specific subtype of astrocytoma, which is the subependymal giant cell astrocytoma, or also known as the SEGA. Now, this is a category of astrocytomas which is typically associated with tuberous sclerosis, and their typical location is at the foramen of Monro, and very often they can be bilateral. Here you can see the other stigmata of tuberous sclerosis, which are characterized by calcified subependymal nodules, the cortical tubers with the radial migrational lines that are evident here on the FLAIR image, and this lobulated lesion, which is seen at the left foramen of Monro, also demonstrating enhancement. These lesions can grow and produce hydrocephalus. Hence, they need to be monitored and imaged frequently to assess whether they are growing. Many of these SEGAs may not show any enhancement, and at our institution, because we want to reduce the gadolinium-associated accumulation in patients who get frequent imaging for their follow-up, we have started doing these studies without contrast, because the main aim of the lesion of the study is to characterize the size of the lesion and also to notice if there is any hydrocephalus that is developing. So remember the association of subependymal giant cell astrocytomas with tuberous sclerosis. Now we proceed to look at the cellular or the supracellular group of tumors. And the main player in this group is the craniopharyngioma. Craniopharyngiomas arise from remnants of the craniopharyngeal duct, and they are of different types. The adamantinous type is the more common one, which has both cystic and solid components with calcification. And the less common is the papillary, which is mostly solid. The typical appearance of a mass supracellular location with the cyst, calcification on CT and a fluid level, and T1 bright signal on the non-contrast MR images is characteristic of craniopharyngioma. The other entities in this group are the hypothalamic chiasmatic glioma, pituitary adenoma, and germinoma, which we already saw before. So, a craniopharyngioma, when you see a CT with a cystic mass in a child with calcification, it is going to be a craniopharyngioma. Another helpful feature on MR imaging, like I mentioned before, is when you see T1 bright, T1 hyperintense material within the cystic components of the supracellular lesion, this is more likely to be a craniopharyngioma. And they can demonstrate varying degree of enhancement following contrast. Here is another example. Again on CT, a somewhat complex appearing cystic mass with calcification. On MR imaging, you can notice the heterogeneous appearance on T2 with the cyst and slightly darker signal on T2, which could represent either calcification or some proteinaceous or blood products. On contrast, you can notice that there is enhancement in the solid component of this mass as well as REM enhancement. Again, same being shown here on the coronal plane. So remember, supracellular mass with complex cystic and calcification within is going to be a craniopharyngioma. Hypothalamic chiasmatic glioma is an astrocytoma, or a glioma, which we already alluded to earlier when we discussed pilocytic astrocytomas. They can be solid and cystic, And you follow these lesions, they're usually low grade, and they can, and very often you can see changing components or increasing cystic components within these hypothalamic chiasmatic gliomas. They are known to encase the vessels, like you can see here in this case, encasing the carotid bifurcation, but still remaining patent. Pituitary macroadenomas can be seen mostly in adolescent children. Among the macroadenomas, prolactinoma is more common, and they can present with secondary amenorrhea as well as discharge or galactorrhea. The appearance is similar to what you would see in the adult population. It's a pituitary lesion within the pituitary gland. And you can see that this has a suprasellar extension, and it causes elevation of the optic chiasm. Again, here you're noticing this lesion has, on the initial scan, it was almost iso to hypointense on T1, but has now developed T1 hyperintensity. So the macroadenomas have a propensity for internal hemorrhage, which is resulting in this T1 bright signal here and T2 dark signal, as you can see here. And you can also appreciate the somewhat lobulated appearance, which results in the snowman appearance, as has been described on the coronal images with pituitary macroadenomas. Now we move on to this unique entity of pediatric brain tumors, which includes the congenital or the neonatal, commonly seen tumors in the neonatal age group. So the first among this category is the choroid plexus papilloma. A choroid plexus papilloma arises from the choroid lining the ventricles. And the most common location is the atrium of the lateral ventricles, although it can arise anywhere along the ventricular system. They have this typical villus or frond-like appearance on the surface. They show intense enhancement and can demonstrate hemorrhage and calcification within. A second entity in this group is the intracranial teratoma. Teratomas are usually large, almost holocranial, or involve almost an entire hemisphere in the newborn or fetus. And the hallmark is its heterogeneity with components of fat, hemorrhage, and calcification within. A characteristic entity, which is known by the name of desmoplastic infantile astrocytoma or desmoplastic infantile ganglioglioma, is a tumor typically seen in infants, and this is characterized by a very large cystic components with some solid components as well. And they typically arise from the cerebral cortex and involve the meninges as well. And on presentation, you may have a difficulty in identifying whether this is an intraaxial or an extraaxial mass. But the large cystic components and the young age of the child should make you think of this entity. So here we have an example of a choroid plexus papilloma, classic location in the atrium of the lateral ventricle, enlarging the ventricle. You can see the lobulated or the frond-like appearance, which is better demonstrated here on the MR images. Intense enhancement, as you can see here, and areas of hemorrhage and necrosis, which can be seen on the CT scan, the mineralization within, and the gradient images or the susceptibility weighted images demonstrating the presence of hemorrhage within. Intracranial teratoma. Now this tumor, you can see that this is almost occupying the entire supratentorial brain. It has components of fat, as you can see by low attenuation CT material here. There is evidence of mineralization and large cystic, heterogeneous cystic and solid components of this mass. So presence of fat, mineralization and hemorrhage in a large mass in a young infant or even in the antenatal or the fetal age group, this is going to be a teratoma. Here we have an example of from a fetal MRI. You can see this large heterogeneous mass, again, mostly occupying the entire cranial cavity, also producing a very typical macrocephaly commonly associated with these large intracranial teratomas. Notice the presence of hemorrhage within this large teratoma. Now, this is an example of the characteristic entity of DIG or desmoplastic infantile gangliogliomas. So when you notice this mass, this tumor has large cyst component and a small enhancing, even a nodular component within it. It may be difficult to differentiate or identify whether this is intraaxial or extraaxial in location when it is such a large size of the tumor. The clue here is going to be the young age of the patient and a large cystic component of the mass, which can be almost occupying the entire hemisphere in this young child. Remember this entity, desmoplastic infantile ganglioglioma. Now I want to briefly touch upon some tumors which may be seen in association with common phacomatoses, such as the neurofibromatosis type 1. We already referred to this entity earlier in this talk. Optic pathway gliomas, which are actually pilocytic astrocytomas, can involve the optic pathway, the orbital components, as well as the intracranial components of the optic nerves, the chiasm, and can further go on to involve the optic pathway and the radiations. The optic pathway gliomas in NF1 may or may not show enhancement. The other features are also demonstrated here in NF1. You are seeing the bright T2 flare bright signal of the spongiform changes which are seen and which are characterized, which are typically known to be hamartomas by histological classification. And you are also going to see many of the cases of neurofibromatosis 1. You can see large plexiform neurofibromas, and also notice the associated sphenoid dysplasia in this case. In neurofibromatosis type 2, we have the classic bilateral vestibular schwannomas that we are seeing here, along with many other multiple cranial nerve schwannomas, as well as enhancing meningiomas, which are very nicely demonstrated here in this case of NF2. So far, I have talked all the entities of primary brain tumors. I want to mention one entity of metastatic tumors to the brain. And in children, this is going to be metastasis from neuroblastoma. Neuroblastoma can arise anywhere in the sympathetic chain. Most common location is the adrenal location. But many times in young children, neuroblastoma can present with cranial masses because they have a propensity of metastasizing to the calvarium. So when you see a child with calvarial metastasis, or another common location is the periorbital location of enhancing lesions, then you have to consider the possibility of neuroblastoma. And this could be one of the presentations of neuroblastoma with just calvarial and orbital metastasis. So remember this entity. So far we completed looking at the common pediatric brain tumors. And to summarize, MRI with contrast is the preferred modality for imaging of brain tumors. Along with the characteristic imaging features, the age of the patient and the location are going to be helpful clues to narrow your diagnosis. And it is important to scan the entire neuroaxis, the brain, as well as the incomplete spine to look for CSF seeding. In case of embryonal tumors, quite typically the medulloblastoma, ependymoma, ATRT, and germinomas, which are more notorious for CSF dissemination. And with that, I thank you for your attention.